welcome to And So Much More. My name is Cami Smith and I am your host. And I am here within the Centra Autism and Development Center with Dr. Bradshaw. Thank you for joining us.
Oh, glad to be here. Thank you for coming.
Of course. This is such a special place. And every year we have the opportunity to talk about autism acceptance in the month of April. And there is so much to talk about and so much to educate and help bring awareness to autism, yes, but also just like that neurodiversity that we're seeing growing in not just our community, but just around our nation, around the world. And so, Dr. Bradshaw, you have an incredible subspecialty, but also I want to just kind of have you share, like, what is it like here at the Autism and Development Center? What do you do?
Oh, thank you for asking. So I am the clinical psychologist here.
Okay.
I have the opportunity to work with an amazing team of providers. I've worked a lot of places during my 20-plus year career, and this team is something very special. We, Lynchburg area, we are able to offer to our area. We really have a large catchment basin for folks. We see people as far west as Roanoke, far to the North Carolina line, and all the way to Petersburg, Virginia. So we catch a large group of individuals coming for assistance. Within our clinic, I am the only clinical psychologist. We also have a child psychiatrist, a nurse practitioner. We have developmental pediatricians here on staff. We also have a full ABA staff and clinic and clinicians, and then we also are rehab folks with occupational therapy, speech therapy, and then we have counselors who specialize with working with individuals with autism, but in general, mental health issues as well. Wow. One of our clinicians says we're the best kept secret, and I agree with her 100%.
Oh, gosh,
That's Lisa Marchand, who leads our rehab folks. They are out of the box thinkers. Our whole staff is, and we really just approach our job. All of us love our job. And it shows with the energy that we have in this building. And we get to work with a diverse group of people. You brought up diversity, neurodiversity. Mm-hmm. I'd just like to talk about awareness of autism, because neurodiversity has always been there, right?
Oh, absolutely.
But it's a matter of recognizing that neurodiversity, the strengths that it brings to the table. Mm-hmm. I believe that we're all created for purpose and reason. Yes. And with the neurodiversity, we have strengths that, individuals who are neurotypical don't have those strengths. So I believe that's, autism is a different way the brain's wired.
Yes.
And I love the opportunity to help parents understand their young children. I work with individuals all the way through adolescence and early adulthood, and helping them understand their neurodiversity is, I think, very freeing and helpful for them and their mental health and their coping strategies.
Yes, that's incredible. And you talk about from young ages to older ages. What's the oldest you've had a patient come in and received a diagnosis?
So it's not uncommon for families to go through this. Okay. And then the parents are like, oh, I have traits too. Mm-hmm. And then they ask for an assessment. I also am the only provider in the area doing autism psychological evaluations. So I sometimes get referrals directly from Piedmont Psychiatric Center. Okay. So I think my oldest has been in their 50s. I've had a referral for up to 70s, but I never was able to see that individual. I'm not sure.
That's incredible to have that level of even self-awareness at that point in your life, to know to take that extra step. Because you mentioned something that I want to revisit, the piece you want to bring to parents. And my son has autism, and I have spoken to many parents who are so nervous to make that step, to get a label, as I've heard it said. And it has changed our life. It's changed our family for the better. But how have you seen that play out in some families? Have you seen that apprehension?
Absolutely. And I see that apprehension among other health providers too. Autism is a label that many are reluctant to say. Mm-hmm. My perspective, and I have many loved ones, many personal friends on the autism spectrum, and I see them as gifts. I see the traits that they have. If we understand those traits, if they understand their traits, I don't see it as something we need to be ashamed of at all. I think a lot of times what happens is that many of our children, especially autism, our medical models has these boxes of this is autism, this is ADHD, this is anxiety. They're not clear boxes at all. There's much overlap between the symptom presentations. So a lot of our children often get picked up for ADHD, and that probably 95% of the children who walk through my door already have that diagnosis. The ADHD is part of the autism, though. A lot of times our girls are being picked up for anxiety. That anxiety, though, is because of the autism and the challenges that they've faced in the environment because their autism's not understood.
So is it more common for boys or men to have autism than girls?
So interesting. Here's a little bit of a history lesson here. So the way that we have measured autism in the past, started in the 80s, they basically sent out surveys to homes and said, do you have a family member with autism? And that's how they got our base rates.
Oh, wow.
Right? Yeah. And the children with more obvious symptoms, our textbook symptoms, our symptoms that are easily recognizable, the pedantic speech, the movements, the interest that is so significant that that's all the individual wants to do and play with or talk about. Those typically are more boy traits. Our books are written about males, biological males. Our books are not written about females in the United States. There are other countries doing much better work with females on the autism spectrum than we are here in the United States. So Australia and the United Kingdom are two hotbeds, and they're really delving into how women look different than men. We can argue, nobody really knows why. There's some argument that it's neurologically based because there are some brain differences between neurotypical females and neurodiverse females that, in fact, there's a big study at UVA, or UVA is one of the places where they're doing that study. So it could be neurologically based. It could also be social. There's lots of research coming 30, 40 years back and continuing today that we treat our little girls differently than we treat our little boys from infancy. We're using different vocabulary, right? So with our girls, for example, restricted repetitive interest is a hallmark of autism. Our boys sometimes have very obvious ones, I'm going to say dinosaurs because for whatever reason, dinosaurs are something lots of our kids love. Trains, automobiles. Our girls, though, are not quite so rigid in their interests. They might enjoy baby dolls. They might enjoy animals. So it's a broader and it's not easily picked up. But what we do see when we kind of look closer at how they're interacting with the baby dolls or the animals, we see some more repetitive, some more rigidity. They struggle more to engage with shared creative interactions. Our folks on the spectrum are incredibly creative many times. I've had the opportunity to work with many young women who are creating these wonderful stories, lots of fan fiction and extending the stories and things like that. Very creative. But the piece with autism that is often misunderstood by clinicians as well as parents, there's a shared creativity that we're looking for. If our folks on the spectrum struggle with that shared, being able to adjust their idea of what the play should look like to meet another person and join with another person in a true interaction. But if we let, our girls tend to be the directors in play. They tell you do this and you do that. So that's a big difference. And I think that's why we're not seeing as many females diagnosed, because the females have less obvious symptoms than the males do.
That is so interesting. Because, there's just so many labels, to your point, that we've just accepted as normal, as fact. And to think of all these young girls who could be receiving the additional care that could really be helpful. I think that's just what keeps hooking into my heart right now is how do we shine a light on this? And so that's why the work that you're doing is so critical. And so I also want to talk about behavior in general, because sometimes when a child has behavior that is fight or flight and really the symptom of something that's so much deeper that's happening, they get labeled as misbehave or the trouble, or I think you said the jokester, And so a lot of times those are the glaring things that we need to be paying attention to that could tell us there's something more going on here. So I want to talk about that, but then also how it relates to girls. Like if their symptoms are so different and not necessarily like behavioral driven in that way, how do we know to dig for more?
Absolutely. So, big topic, which I could talk about for hours actually, because I love understanding folks and helping them understand themselves. We often, because one of the other, I brought up restricted repetitive patterns of behavior.
Mm-hmm.
One of the kind of hallmark symptom clusters is cognitive rigidity for autism,
Okay,
right?
yes.
Black and white thinking. Things are one way, not the other way.
Yes.
A lot of our folks, because of that cognitive rigidity, struggle to problem solve, especially when their stress is high. Okay.
Yes.
And when there's an emotional content to the stress, like if I'm in a dynamic with another child and we're trying to negotiate something, the ability to problem solve is going to be impacted because it's a more stressful emotional situation.
Yes.
So what happens because of that cognitive rigidity, they have a plan A, but then when that doesn't work, things fall apart, literally and figuratively, right? We see aggression increase. We see big emotional reactions sometimes from our kids.
Yeah.
And for parents, I often hear they get so upset about the littlest things. And it's because of that cognitive rigidity, because they're in the here and now, and they're not thinking about next step. They're kind of stuck in that focus on the one problem. So what we see emerging, I really hate the diagnosis of oppositional defiant, because a lot of our kids get labeled that. And you brought up fight and flight earlier. Sometimes teachers, sometimes parents don't recognize that oppositional response is a fight response to anxiety, right?
Yeah.
We have children who need to control what's happening to them. And so if they're uncomfortable with the next step or cannot transition or are not ready to transition, it's pretty common that the kids that we see that come into our office are having those big emotional reactions, the refusals. Again, this is out of the UK, pathological demand avoidance is a term. It's not a
I've
clinical,
never heard that.
it's a fantastic, I recommend that most parents look into it,
Okay.
and teachers too. I'm always sending out information to schools about it.
I love it.
Pathological demand avoidance comes from that rigidity.
Okay.
A lot of our folks are perfectionistic. The thought of making a mistake is horrifying. They would rather upset the parent, upset the teacher, than to feel like they've let themselves down.
Wow.
A lot of our folks are, the perfectionism, they have higher expectations on themselves than anybody puts on them.
Wow.
And so what we see happening is the big emotional reactions if they don't get things the way they need them to be, or we see a complete, I can't do it at all.
Yeah.
And they look like they have no motivation, but it's more the fear of what if I don't get it right.
Yeah.
Our folks struggle with something we refer to as alexithymia. Alexithymia is kind of a disconnect between what I'm feeling and why I'm feeling that way and how it's manifesting in my body.
Okay.
They have just an overwhelming, when I talk with folks, they describe like overwhelming waterfall of negativity, and they can't really understand why or what triggered it sometimes.
Gosh, and what that must feel like as a child.
Well, the child is argumentative.
Yeah.
And then they get in more trouble. And cognitive empathy is another area that's a challenge for kids with autism. Cognitive empathy, it's also referred to as mind blindness.
Okay.
They don't automatically think about the other person's perspective.
Yes.
By about age 6, neurotypical children have that ability. So they recognize quickly how their behavior has impacted others. Now, they may not want to admit it, but they know. And there's some remorse afterwards, right?
Yes.
But our folks don't recognize that, hey, because I tore my paper up and yelled at the teacher, it impacted the kid next to me. Maybe they were fearful because they were afraid I was going to throw something at them. They don't think about the impact on others because of that neurological difference. So, but then when things are calmed down and this is something we focus on with therapy and intervention too, helping them recognize their role within interactions.
Yes.
And then developing new plan B, C, and D
Yes.
for the next time that they're in that situation.
That's so incredible. I mean, we saw when my son was so little, the explosive behavior, and we were in that stage where we were timing the tantrums and see what would impact or reduce the time of the tantrums. But what we started noticing and he's incredibly strong, as he did the work and as we did the work, we called it the big hump. As he got over the hump of the emotions, he would come back to us and start to talk about what he was feeling.
Good.
And it was incredible because,
Right.
I mean, we knew he could not do that in the moment.
Exactly.
We had to wait until we were on the other side of the big hump to have that conversation. And it's so eye-opening. And it also gives some hope, I think, because when you're in those big moments, it is the most helpless feeling as a parent. And so to know, like, okay, if I can patiently sit with my child to get over the big hump, we're going to get to the why. We're going to get to the help and the reason and how do we do this different next time? And
absolutely.
It's so worth it. And so, yeah, I mean, I always encourage parents to just look a little bit deeper, be open to it because it's huge. But it's so interesting to hear what's really happening from your perspective, because I have like the experiential, and you probably do too, but the like in the moment I've experienced this with my child, but in a lot of cases I may not have the words behind what is actually happening here.
And these things happen in the grocery store.
Oh,
and everybody's staring and looking and passing that judgment, and I feel for parents. And, autism are folks with, milder presentation of the symptoms have more internal, right? So it's invisible. It's an invisible disability. And so a lot of times the grace that we give another family, we don't give to individuals who are parenting kids with, the traits of autism that are more internal. I like your analogy of the hump. I like that because as adults, teachers, parents, why are you doing this? That's our initial, that's our first go. And then the kid often says, I don't know, or gets more angry because they, in that moment, because of the alexithymia, they truly don't know why they're doing it.
No idea. And a lot of teachers would try to parent in that, or not parent, but teach in that moment. And I found myself trying to parent in that moment before we knew, this is getting nobody anywhere. We need to take a pause. But yeah, it's extremely helpful. What would be the thing you would want someone watching this who's maybe asked these questions about maybe themselves or their child, or now hearing what you're explaining with girls, they may have someone in their life. They're like, wait a minute.
Right.
This is what could be going on. What would be your message?
I think that, let me kind of speak to providers and to clinicians first. I think that anytime we have a child with oppositional tendencies, severe oppositional tendencies, with eating disorders, with big emotional reactivity, disruptive mood dysregulation diagnosis, things like that, I would want to rule out autism for our females. Our females often are have an anxiety diagnosis, the ADHD diagnosis. Personality traits are emerging by the time they're in their teen years because they develop strategies to manage their social delays that might not be as adaptive as they should be. And it results to impact on interpersonal relationships. I think with parents, understanding neurodiversity, that with autism, there are strengths within autism as well. I tend to pick on a few different fields. We have many medical providers who have autism traits. And it helps them in their medical field. Nurses, doctors, surgeons, we want them to be highly technically minded, focused on, the task at hand. So I think looking at the autism traits as how it's a strength, restricted interest, working with individuals, like for example, vehicles. That sends, a lot of my little guys love vehicles. Well, I'm always thinking about employable skills, how does the engine work? How do we help them, if they're college bound?
Let's hone that.
Let's learn more about that vehicle instead of just doing the repetitive play. Let's find out how they work. Let's see what the engine sounds like.
Very cool.
Just doing like almost a sensory exploration with these areas of restricted interest, I think can really open up more possibilities and help kids start to see things more flexibly.
I love that. So what would you say to an adult who is maybe questioning, oh my, has this been a part of me this whole time and I didn't know it? I can't imagine at a later point in life really, I mean, it would probably just make things so clear.
When I
looking
work,
back.
the majority of the biological females that I've worked with have had a sense of relief after the diagnosis.
Wow.
Because they've had many diagnoses during their lifetime, and
Yeah.
because of cognitive rigidity, a lot of individuals have rejection sensitive dysphoria, where they are really pretty hard on themselves, and any kind of mild correction from a parent or a teacher they take as, I've done something horrible. It's
Wow.
that all or nothing thinking again. So it leads to impacted self-concept, feeling poorly about themselves, not giving themselves grace. So I think that for our females on the spectrum, it's very helpful to get the diagnosis. There are few providers that diagnose, though, in the area or feel comfortable diagnosing, especially biological females. Some people say it's a bad thing, some people say it's a good thing, but there's an explosion of social media, TikTok, channels that are on neurodiversity, and everyone has ADHD, everybody has. But there is some truth to that. I think people are taking to social media to talk about their experiences in that media. So I think there's a lot of information about neurodiversity, good TED Talks, good research out there. And again, for women understanding their own traits, the information coming out of the United Kingdom as well as Australia are really good resources.
Okay. Where would they find some of that information?
Honestly, Googling neurodiversity, high functioning autism,
so this
female
would be an
autism,
instance where Googling is okay.
Yes. Well, again, yes.
Cautiously.
There's a lot, cautiously, because there's a lot of great Facebook groups out there.
Oh, wow. Oh, I
for
bet.
women, and I'm prefacing biological females because a lot of our individuals also feel diverse regarding their gender identity.
Yeah.
So biological females, there's lots of folks online. I can think of a handful of Facebook sites where people are sharing their experiences. And I think when people do share their experiences, there's like I'm not alone.
Oh,
it's not just me. And I think that can be very freeing.
Yeah. Absolutely. Well, I have learned so much in the last 10 minutes. It's incredible.
I'm very excited. I just finished a chapter on disruptive mood dysregulation disorder and the comorbidity with autistic traits, because I feel like we're just, misdiagnosing. It's not a misdiagnosis. Because we do have disruptive mood sometimes.
Oh, yes.
But I want people to understand how females present. Haven't brought up masking or camouflaging.
Yeah.
Our women exhaust themselves. Our biological females masking and camouflaging, and maybe it's because of the social pressures.
Okay.
Our women are more likely to, is what it said, mask. They may choose a character on TV. They may mask their parent, and this is a successful person, this is what I need to do. So the long-term implications of that is that it doesn't feel authentic to them. And who am I? Yeah. So identity development is impacted, and there's a physical fatigue, which can resemble a major depressive episode, which we refer to as autism burnout.
Yeah. Wow. There's so much more we could probably sit here and talk about, and I would love to do that. But I encourage those who are listening, who maybe still have questions, to do some research on your own, but then also talk to your primary care provider about what types of services or referrals that you can get into place to begin really having these conversations about your children, about yourself, about a loved one. Take the step. It is so, so worth it. And thank you for joining us.
Thank you for coming.
Your time. Yes. And thanks for joining us today on And So Much More.